I'm sure people have like, their to respond to their kids and stuff. So
Exactly. Yeah. Well, let's just go ahead and get started then.
sure.
Do you have slides that you want to share? We'll make sure
I
that those work.
I do. Before I get started, I'm curious of like like how familiar are we with PCOS?
Um, so Connie is the clinician who's attending,
Connie is a clinical pharmacist.
clinical pharmacist. She probably does have some understanding of PCOS since it is something that sometimes we prescribe medication for. But I don't know, Connie,
Yep,
if you,
I'd say I have some understanding in treatment,
okay,
but not at the level of like a PCP.
right. Okay, and Michael is one of our patient advisors.
Fun.
Zero. Never heard of it
Yeah.
before.
No ovaries of your own.
No.
Uh, okay.
All right.
Well, that's helpful for me to know. I'm just trying to think. One, I think I'm at a point where I know too much about PCOS, and so you end up just like hacking your slides with so much information. So I was trying to figure out like where do I kind of adapt here, and really um in the time that we have, which is like not a lot of time. But yeah, I thank you, Anne, Robin, Liz, for inviting me to present to these learning communities, and and I can also understand like sometimes just coming to a noon talk is like one of the last things people want to do. So I also appreciate maybe a little bit more of an intimate group to talk about this. So what I am going to share with you all is weight focused or weight neutral approaches for PCOS. What do we know works, and what is it that patients actually want? For folks who don't know me, my formal name is Pudaman, but most people know me by my nickname Noi, Pimpasan Brady. I'm assistant professor in the Department of Psychiatry here at CU Anschutz. I also co-direct our CU Anschutz multidisciplinary PCOS program, and I'm a clinical health psychologist and implementation scientist by training. So I don't have any disclosures related to this or conflicts of interest. I went to someone's talk once at a conference, I think last year, and she said she doesn't have any conflicts of interest, but would be very open to it. So I feel like I'm also open to a conflict of interest. And I just hope that, however we go with this conversation, that this, starts to kind of stimulate and challenge maybe any initial perspectives that you have about weight in PCOS. So to kind of set the stage a little bit, I'm going to start with talking about a case. As a clinical health psychologist, and I have been as an integrated psychologist in many different settings. Actually, before I go to that, I've been a psychologist in many different settings. I've been in a women's health. I've been in primary care for a really long time. I was an integrated psychologist at a women's health primary care clinic, and now I'm integrated in our OB-GYN clinic. So I have been in integrated care for a very long time. And this case I would say, is a very typical case that I would often receive, be referred by, patients PCP. So I'll read it really quickly. Maria is a 30-year-old female. She was referred by PCP for depression and anxiety management. She has a long history of irregular menses, acne, and challenges with weight. She's being worked up for infertility after 2 years of trying. She's been frustrated by her medical care and is often told to lose weight and eat better. Despite being active throughout her life, played organized sports in high school, as well as being mindful of nutrition, weight loss for her seemed to really only occur if she was in this really restrictive kind of behavior. So intermittent fasting, excessive exercise. And she's also received similar messages from her family about her shape and weight. And has felt frustrated and helpless, with feeling consumed that all she thinks about is her weight and her body, and feels that her efforts have been fruitless. As you hear this or read this through, what comes to mind for you? What strikes you about this person?
Well, it seemed-
as a dietitian, I worry about disordered eating coming on as an effect.
As a provider, I worry about it's like getting a similar message. It's like kind of like your fault on the weight gain and having to like do that, and the family's kind of re-emphasizing this, and the kind of hearing it from other, if it's other clinicians, and not this whole thing that it's something that maybe she's doing wrong.
Mhm.
Great.
Yeah, I think what stands out to me is it seems like she's doing everything right, right? Like she's exercising, she's been, mindful of nutrition, and yet she struggles. So I think I would be thinking, what else is happening here?
Yeah. Yeah, absolutely. Yeah. All of those, I would say, hit the nail here. And this is someone that this is like a mix of patients that I've seen, but would be, I would say, a typical example of someone that I will see often with PCOS. And, they're not always referred to me for like PCOS specific things, but they're referred to me for depression and anxiety. And then, I feel like I end up having to go and clean up a lot of messes that people have made along the way. So for folks who, just kind of a quick run through of PCOS. So PCOS stands for polycystic ovary syndrome or polycystic ovarian syndrome. Both terms really apply here. It's considered the most common endocrinopathy that affects females. So it's considered a female-specific endocrine metabolic condition, and it affects 1 in 10 females or people who have reproductive ovaries. And up to 13, the prevalence is up to 13% globally. So this is like a very well-recognized international condition as well. And the interesting piece about PCOS is the symptoms can start as early as adolescence. So really 2 years after someone has started their menses or their period. And the symptoms can actually persist and last through the menopause period. So we're really talking about a very large proportion of the female population who could have PCOS. The challenge is too is that 70% of people still remain undiagnosed with PCOS. So even though we're talking a really large proportion of people who have been confirmed with PCOS, we're still missing a really large number of folks who are undiagnosed with PCOS or have symptoms of PCOS that can worsen their health. In terms of kind of the pathophysiology, there's still some more research that needs to be done. But what has really been proposed, or what seems to be consistent, is it's this complex, this vicious cycle that involves primary ovarian abnormalities, insulin resistance or hyperinsulinemia, and then neuroendocrine modulation. So, as a quick run through, really in people with PCOS, there's typically this surge. Let me get my little laser pointer. There's typically the surge in progesterone during the luteal phase of the menstrual cycle. This really helps to regulate GnRH pulsation or gonadotropin release hormone pulse frequency. In PCOS, this surge doesn't happen to slow this down. So really there's GnRH, this abnormal pulsation just keeps happening. It's just kind of firing all the time, which then really leads to an increase in this amount of LH over SFH hormone ratio. So luteinizing hormone, increase in luteinizing hormone over follicular stimulating hormone. And so what this does is this increase in LH or luteinizing hormone stimulates the thecal cells in the ovaries, which then ends up overproducing androgens in the body. So essentially like overproducing like higher testosterone in females. That results in ovulatory dysfunction, or your menstrual cycle is essentially irregular. And then also follicular arrest, meaning your eggs, for females in a normal menstrual cycle, your eggs don't actually end up maturing, fully maturing. so you're not really going through the full menstrual cycle, and then you just end up having, this is why infertility is also really common in this population. But your eggs just don't end up maturing. This also results in hyperandrogenism or higher testosterone. The challenge also with higher hyperandrogenism and higher testosterone is this also affects insulin resistance. So people's bodies' inability to regulate insulin properly. And that's the insulin resistance that is present in the muscles and in the liver. And interestingly, insulin resistance or hyperinsulinemia also increases androgen production. So it becomes this whole feedback loop where you have insulin resistance, and then it ends up having increasing hyperandrogenism, and at the same time, your body is also going through this other process with the menstrual cycle. And so and then you never really move to ovulation, so you're never really fully transitioning through the menstrual cycle. And so then there's no progesterone to stop this process from overstimulating, and then you just end up being in this cycle every month. And so I'm trying to do this in a way that, like, it makes sense, but it's, or if like it's more of a layperson's perspective on this. But I think what's most important really to understand in terms of the contributors of PCOS is this experience of hyperandrogenism, so higher levels of testosterone, as well as insulin resistance. And how those symptoms actually show up are the three primary symptoms are the symptoms that we use to diagnose PCOS is. So androgen excess. For some people, that could be like clinically, that's hirsutism. So like increased facial hair, unwanted body hair, increased acne, cystic acne. Biochemically or through someone's labs, it could be higher levels of testosterone. The other symptoms are polycystic ovaries. So that would mean like excessive follicles in someone's ovaries, or having polycystic ovarian morphology. And that's normally determined through transvaginal ultrasound. And then the other symptom is menstrual irregularity. So having either a really long menstrual period, going, less than eight, I would say like 8 times within a year of not having a full period. And then for some people, it's just having really infrequent periods or not having one at all. So we have some patients who report to us saying they've not had their menstrual cycle or their period in like 6 months, or they end up having really heavy bleeding. And so you can see some of these symptoms really will vary across people. We now use the NIH 2003 Rotterdam criteria, where you really only need 2 out of the 3 symptoms in order to be diagnosed with PCOS. So you actually don't even need the polycystic ovaries. And in some ways, that is kind of a misnomer. Like the name PCOS is kind of a misnomer because you don't actually need the PCOM in order to be diagnosed with PCOS. And the challenge with PCOS, and maybe one of the reasons why 70% of people are not currently diagnosed with PCOS, is the diagnosis has really varied. So first it started with the NIH 1999 criteria, where they really focused on just these 2 symptoms. And then the Rotterdam criteria came out that looked at all of these 3 criteria, and then the AE-PCOS criteria came out. And so I think it was finally formally recognized that we should be following this criteria here. The additional challenge of PCOS is, as folks who are providers know, is PCOS is a diagnosis of exclusion. So you have to really figure out exclude other thyroid issues that could be contributing to some of these symptoms before getting to a diagnosis of PCOS. So you can imagine that can take a really long time for people to actually receive a formal diagnosis. What is also contributing to the kind of the complexity of PCOS is now there's this greater understanding of PCOS phenotypes. So the symptoms of PCOS presenting differently across different groups. So, there's this notion of phenotype A, which is just really classic PCOS and having all three symptoms. Phenotype B is having symptoms of ovulatory dysfunction or menstrual irregularities, and then hyperandrogenism. Phenotype C is PCOM, polycystic ovarian morphology, high androgens, and then phenotype D is the PCOM and then the ovulatory dysfunction. So while I think this is nice to have it in the PCOS phenotypes, I think clinically it's really hard for people to know like how am I supposed to treat this if you have like, do I treat you different if you have phenotype B versus phenotype C? And the challenge is like we just don't have enough information around like what is the most appropriate like treatment patterns depending on your phenotype. The phenotypes are also, let me add another complexity about PCOS, is that the phenotypes are also driven by race and ethnicity, or really ethnicity in particular. So Caucasian women or Caucasian females in North American and Australia tend to have more of a higher body mass index. Folks with African ethnic background tend to have present with higher BMI, metabolic syndrome features like high blood pressure, cardiovascular disease risk. Folks who of a Middle Eastern or Hispanic or Mediterranean background tend to have more severe hirsutism, so like more severe like facial hair. And then folks who are Southeast Asian and then Indigenous Australian tend to present more with like increased central adiposity or central fat, insulin resistant diabetes, metabolic risks. And then acanthosis nigricans is essentially dark discoloration on your skin and kind of in and around your skin folds. And then East Asians tend to present with lower body mass index and milder hirsutism. So you could see it's hard to like, if you have a patient presenting in front of you, it's hard to really know like, oh, what's my sign or what's my clue that this person might have PCOS? And I think that's been kind of that's a tricky target to do, and especially, in primary care where your time, really is limited with patients. In addition to kind of the many consequences associated with PCOS, we have focused a lot on kind of what the metabolic consequences of PCOS have been. Folks with PCOS are 50 to 80% of them are more likely to have 4 times higher to have long-term overweight and obesity, certainly higher risks of type 2 diabetes and impaired glucose tolerance, hyperlipidemia, obstructive sleep apnea, higher odds of that. This is even when controlling for BMI. So BMI is not a contributor for sleep apnea in this population. Non-alcoholic fatty liver disease, which I know there's a new name now and I don't know what it is anymore, but it's can be as common as 40% of people with PCOS, and then 30% to twofold higher incidence of cardiovascular disease. So I think you can imagine why, like, with all of these different metabolic consequences that are associated with PCOS, that care for a really long time for PCOS has focused on intensive weight loss, PCOS care. But before I get to that piece, so, and I'm curious to hear from you all, like, yeah, when you think of intensive weight loss PCOS care, or just kind of intensive weight loss, what comes to mind for you? What is that like? What do you do with those in this approach?
I can say that the intensive part is hard to do because of access and time. So to do the intensive, I have to include like the whole team. And so I have to start incorporating our psychologists and our
Mhm.
our nutritionists and stuff, and like kind of do a lot of intensive that way with all of us, like kind of one, seeing where
Mhm.
I guess what type of PCOS is going on. Thank you for telling me a lot of information, but like kind of understanding that better
Mhm.
for that particular person, and then kind of personalizing and focusing on that intensive part, on like where it's needed to focus on the weight loss part.
Mhm. Yeah, great. I don't know if you wanted to add something else.
Oh, I think also thinking about, you know, behavioral weight loss, but potentially medication, using pharmacologic aids that, I know metformin's been used for a long time. I'm actually not aware of studies specifically around PCOS and the GLP-1 receptor agonist, but I would imagine that's been looked at as well.
There's one right
Mhm.
now at University of
Mm.
Colorado,
Great.
children's, I think they're doing a GLP-1 PCOS study.
Melanie
Yep.
Cree.
Yep.
Mm-hmm. Yeah. Yeah. And I think I think what you're all sort of hitting the nail on, you're hitting the nail on this, but I think in terms of where I kind of sit as a psychologist in this space of, I think one of my roles I really see as kind of a liaison or a communicator between patients and their providers. And sometimes, describing it, and I feel like, in some ways I'm probably preaching to the choir around this, but, describing it as intensive weight loss care can feel like really hard to do, especially within PCOS specifically. So what I think my own language and how I have been trying to reframe it for myself and as well as for patients is really this notion of weight focused care. And I know I'll go through sort of what I mean by weight focused care, but spoiler alert, it's the things that you're already doing, with a little bit of just like inclusive language behind it. So in terms of kind of what this actually looks like, the 2023 PCOS international guidelines, their focus, and I think for those who have managed PCOS, lifestyle interventions and lifestyle changes has been the primary focus within PCOS. The international guidelines recommends that exercise alone or multi-component diet combined with exercise and behavioral strategies should be recommended. Lifestyle behavior should encompass healthy eating and physical activity to optimize general health, quality of life, body composition, and weight management. And then certainly they had talked about achievable goals such as 5 to 10% weight loss, and those with excess weight can yield significant clinical improvements and is considered successful weight reduction within 6 months. And yeah, I think, Anne, like you said, a weight focused approach or what is typically done within PCOS is this, metformin is very commonly used because it addresses the insulin resistance piece of PCOS. And you can consider kind of other insulin sensitizing agents. The international guidelines also say that you can combine with the combined oral contraceptive for folks who have a BMI greater than 30, or with diabetes risk factors, impaired glucose intolerance, or who certain ethnic groups are high risk. Some patients, though, as you probably know, they can't tolerate metformin. Metformin comes with some pretty gnarly GI side effects. And sometimes patients, I think PCOS in particular, the feeling is like, oh, this medication doesn't even really work for me. So there must be something wrong with me. And so sometimes even encouraging like inositol, which is an over-the-counter, essentially a supplement, and our endocrinologists would call it a plant-based metformin, could be considered, but I think counseling patients on there's really limited research out there. Some patients really benefit from inositol, some see no difference at all. And so discussing with your patients around that. anti-obesity pharmacologic agents. The international guidelines also recommend that as well. I have personal feelings about calling it anti-obesity, but this is just the day and age that we live in. And these would things be like liraglutide, semaglutide, and then the GLP-1s, and then bariatric and metabolic surgery are also recommended as well. And so, yeah, and like you mentioned, metformin has been used really often, but now with these, there is really an influx of research of really these GLP-1s and the anti-obesity medications and how they affect weight loss and other kind of metabolic indicators within PCOS. So in this study, they did a 24-week randomized controlled trial of exenatide metformin or exenatide plus metformin. And really, you're seeing across the board, it does improve. It all resulted in weight loss. Certainly, when it's a combination of the two, you get a higher percentage of weight loss. And then you also see improvements in total testosterone. I can't recall what FAI is, but the HOMO-IR, which is insulin resistance, and then also this is insulin sensitivity measure. So really, you could see that they do improve metabolic indicators. Other studies that have been doing this within PCOS is, they've done a randomized trial of liraglutide compared to placebo, a 26-week trial among 65 women. Liraglutide resulted in 5% weight loss, and then saw improvements in some of the reproductive indicators of PCOS. So reduction in free testosterone, reduction in ovarian size, and then a trend for decreased AMH, anti-Müllerian hormone, and then the antral follicle count, and then metabolically reductions in A1C, fasting glucose, and liver fat. And then of studies that have done the randomized trial of liraglutide, metformin, and the combination of the two, within this 12-week trial, you could see weight loss that occurred across the groups, with weight loss being reduced more in the liraglutide plus metformin. But in terms of reproductive outcomes, they didn't see any changes in the androgens, no changes in menstrual frequency. And then really, there was just a reduction in the 2-hour oral glucose tolerance test. So you could see in some studies, we're seeing improvements in weight loss, improvements in some of the metabolic indicators, but then in other studies, we're not seeing improvements, and we're primarily seeing improvements in weight loss. So there's still, I think the research around this is still pretty mixed in terms of outcomes. Also, sample sizes are still, they're remaining pretty small. 65 women with PCOS and the 40 women, I think we're still needing more greater sample sizes there. And then, semaglutide or semaglutide studies have found that in clinic observational trials, women who failed to lose weight with lifestyle modification, they were then treated with semaglutide for 3 months, and they did find that they were able to continue to respond for another 3 months. So for a total of 6 months in this trial. So it's essentially like if you did not do well on lifestyle medication, then they transitioned you to the semaglutide. And we do see reductions in body weight, and then differences with fasting glucose and insulin, and then 78% were able to have normal menses. So the weight focused approaches in PCOS, they work, and people do lose weight, and some of their metabolic indicators do improve. I think the challenge and where I find myself as a psychologist who works with a lot of people, has been working kind of in this weight focused area for a long time, is now this kind of, the GLP-1s have kind of opened up this new game of like more psychological harm, I think, in some areas, especially if you notice this experience of weight regain. And I think this is where it's really important. In this study, they found that people who were on semaglutide ended up, after 52-week off this treatment phase, you could see they started to have this weight rebound effect. And so even though they didn't necessarily go back to baseline, I think from a psychological perspective, that can cause a lot of harm to people where they're like, these medications really worked for me when nothing else worked. But now I've gained it all back. And so it kind of reinforces this notion of like, whatever I do, nothing is going to work for my weight. You could see, so this is across the entire trial. And then you could see here, this is like based on 5% body weight or yeah, about the percentage of weight loss. Yeah. Yeah, I think that's a good point too, Anne, of like, you know, and I think that's a hard part of being in this space now is they don't want to be off of them, but they also know that they don't want to be on them long term.
Mhm.
So,
Yeah, I
so
think,
it's really hard to like, yeah,
yeah, I
manage
mean,
that.
when people ask me, well, I have to take this forever, I say, well, right now it does look like people gain weight back when they go off. I think it does give you the opportunity to work on some of those lifestyle changes, if you want to call it that. Like, you know, as you lose
Mhm.
weight, exercise becomes easier and you can keep exercising when you're not hurting as much. But, you know, most of the data shows, at least for a large portion of people who use GLP-1s, that they will gain weight back if they go off. Michael, looks like you have a question or comment.
Well, and we need to also remember that people are being forced off by their insurance company.
Yes.
And so that's going to
true.
be a piece of it
Mhm.
where
Yep.
it's not their decision. It wasn't a decision they made for themselves.
Yeah.
And so something is
Very true.
being ripped out of their hands, with the alternative being, where do I suddenly come up with the $1,000 per month that I need to be able to have this? And also, even if I try to use some program, it can be how many more weeks before I have it back in. And so it's a devastating impact for people. And it does fall into that trap of, I can't seem to manage this. I can't control it. I don't have control of what happens to me
Yep.
in my life.
Mhm.
Which
Mhm.
doesn't, you know, help, I would think, psychologically.
No,
That
no.
sense of not having control.
No, absolutely. And I think that's where, like with PCOS in particular, I think weight loss in general or kind of weight management in general, there's a high sense of this illusion of control. Whereas, you know, there are a lot of things, you know, outside of your control that can make it challenging to lose weight. And some of the experience in it with PCOS in particular, they're, you know, they are more likely to, experience, you know, they're at increased risk for disordered eating. And this is where I sometimes I worry if we focus too much on weight focused approaches to care, because this is a group that they're 4 times more likely to develop any eating disorder. There, you know, certainly is research to suggest that it reinforces weight related stigma and discrimination. So some of the things that we've talked about already. But you know, this it has led to like ambivalence to access healthcare experiences, avoid or delay health services, this perception that weight is entirely under your control and that the lack of weight loss is your fault. And some of the messages that my patients have gotten around around weight in PCOS is, you know, you just need to lose weight and then all of your PCOS symptoms will go away. And maybe if you exercise more, your hormones would balance out. And you know, I think it's these messages are, and we kind of know the experience of like weight stigma and obesity stigma, and I think that's where, you know, the joint international statement came out for trying to end stigma of obesity. So you know, I won't go through this for the sake of time, but you know, this pledge of treating individuals with overweight and obesity with dignity and respect, and then refraining from using stereotypical language and images, and to encourage and support educational initiatives aimed at trying to eliminate weight bias. And this is something that we also did within our focus groups, and really what we found within our focus groups. So we conducted focus groups of patients who, about their current PCOS care, what they've, what they've experienced in the past, and what's been kind of a primary driver for them. And what I would really hone in on is, our main theme was this long delay and dismissal in PCOS diagnosis and care because of their body size. So regardless if you are kind of at the higher weight side or the lower weight side, PCOS testing was delayed. Symptoms were often attributed to body weight rather than the medical condition, rather than to medical conditions in participants with larger body size. So these were comments from quotes from participants. And I think this one in particular, it really resonates with me. Of this patient said, my first endocrinologist looked at me and said, I'm so sick of just diagnosing just another fat woman with PCOS. And that has always really stuck with me. This person, I've gone to prior OBs and have left really, really sad. I'm like, well, I'm just fat and I'm trying, but it's not working. And you kind of leave defeated. And then, these comments around like, oh, your body type doesn't suggest that you have PCOS. And, this would be someone who maybe has a lower body weight, but their symptoms were dismissed because, they don't look like a PCOS person. So you could see a lot of these comments that patients have gotten from providers really do stick with them. And this is where, for us who in this kind of PCOS space, knowing that, this has been a longstanding experience in PCOS, as well as I would say like in other conditions, of now trying to move more towards this kind of weight neutral or inclusive care. And I feel like it sounds like many of you, you're all doing this. So I'm not, again, I'm preaching to the choir, but what this could look like is, trying not to conflate weight with health, trying to work on eliminating this notion of health or what health or unhealthy weight is. And I think that's still really controversial, given, I think, the healthcare system that we're in, as well as the societal expectations around weight and body size. Working to addressing weight bias, and it acknowledges this experience of health isms. So knowing that our healthcare system does reinforce certain biases and discriminations around weight. Providing bias-aware medical care and addressing bias with learners. Cultivating safe, shame-free environment for patients of diverse body sizes, and that reduces focus on weight loss as the only outcome, and then striving to increase health and healthcare access for individuals along the weight spectrum. And because of patients with PCOS, their prior experience with weight discrimination and weight bias, and how it's led to delays in care, we then developed our weight neutral multidisciplinary care for PCOS. And what this looks like is really, you have the patient with PCOS. This is housed in our gynecology clinic, and was funded by a grant from the Department of Health and Human Services. And, the person with PCOS, we are centered around this core team. So our gynecologist, our nurse navigator, our nutrition expert or a registered dietitian, and then the health psychologist. And really in that first visit, they get us all at once. They see us all at the same, we kind of transition in at the same time. And our nurse navigator in the beginning will call patients and will give them, and will really provide a fully comprehensive assessment around their PCOS care goals. And so they already come to us knowing that we're going to be comprehensive. And then within this first visit, they see the gynecologist, and then they see me, and then they see our registered dietitian. And we focus on different aspects and different goals. And then we have established different referrals and workflows to we call them PCOS aware providers. So people who are familiar with PCOS and understand kind of the not just the the reproductive and metabolic effects of PCOS, but also kind of the psychological effects of PCOS and how that can impact someone's engagement in healthcare. And so how we put our weight neutral multidisciplinary care into practice is we introduce our model of care as weight neutral. Like we kind of say on the front end, like, yeah, we know that weight discrimination and weight bias is really common in PCOS. So our focus is not just focusing on weight as our only outcome, but other outcomes that might be important for you. Providing comprehensive education on the health effects of PCOS, particularly around these 3 areas. So the reproductive health issues, the metabolic, as well as the psychological health and sleep issues. And so they really get a lot of this information on the front end. And then we start to facilitate a shared decision-making process on each of these different areas. Our gynecologist also does a lot of education around how these 3 different areas are intertwined, so that and really the overall goal is we're not just focusing on weight loss or weight and trying to change and manipulate weight, but we're really focusing on more of this like whole person, patient-centered approach to PCOS care. And some of that could also be, some of the treatment plan does include kind of the weight focus approach that we mentioned, but also this encouragement of other like dietary and lifestyle factors. And so what we've seen in the research, or what's been in the research, is, certain nutritional supplements can help with different symptoms of PCOS. There's been emerging research around kind of alternative medicine approaches, so like acupuncture or different herbal treatments, and then certainly being mindful of different dietary patterns. I think what we really try to emphasize to folks is, there is not a specific diet recommendation for PCOS, so there's not a restrictive diet or an intermittent fasting diet, but it's really mostly about encouraging whole foods or grains and foods that impact insulin resistance. Our education involves like, we're trying to help you manage insulin resistance, which could lead to improvements in these other health areas. And our dietitian also focuses a lot on, and she does like intuitive eating approach to care, as well as helping them, with specific nutritional recommendations. And she has been running a really nice intuitive eating group for folks.